Hello everyone, this is Lena Press and I'll be reviewing the Igel supraglottic airway updates for the new ICEMA policy here for spring of 2022. So we'll walk through the education and what to expect with using the Igel in the field, and hopefully use this as an opportunity to get you guys educated, and then if there's further questions, get you in touch with your educators to learn how to use this. We're really excited to have the Igel, and we'll walk you through some of the objectives. So the objectives for this education are to discuss the advantages of Igel for a difficult airway when intubation and BVM fail in the field, identify the equipment needed for the placement of the Igel supraglottic airway, discuss the methods of Igel placement and troubleshooting complications, discuss indications and contraindications for Igel placement, and then demonstrate proper use and confirmation of correct placement of the Igel airway. Again, all of this is just our way to try and help you guys get ready to use this in the field and make it as successful as possible whenever it is needed. So we wanted to give you a chance to look at exactly what the policy will look like in the ICEMA protocol, and I'll just kind of read it through for you. The supraglottic airway is permitted only in patients who are unsuccessfully managed with a BLS airway and oral tracheal intubation. So this is basically someone that you're having a hard time bagging with BVM. You've successfully attempted your endotracheal intubation, or you've attempted your endotracheal intubation and unfortunately been unsuccessful. So this patient still needs their airway managed in the field. The supraglottic airway is permitted only in patients who are taller than the maximum length of the pediatric emergency measuring tape, or the Broslow, measuring when you measure the individual from the top of the head to the heel of the foot. You have to monitor end-tidal CO2 and waveform capnography. You must monitor pulse ox. And if you're unable to place the supraglottic airway after 3 attempts, which an attempt is defined as the placement of the soft gel of the Igel into the mouth, just continue as best as you can with your BLS airway and proceed to the nearest hospital ASAP. And then document verification of your supraglottic airway. Just a little bit about the Igel. The Igel is a supraglottic airway device, meaning that it is placed above the epiglottis. Therefore, it does not pass through the vocal cords. The Igel is one of these devices and can be used as a backup or alternative to a BLS airway and endotracheal intubation. It is a single-use, sterile, latex-free supraglottic airway. So if you kind of look at the anatomy, which sometimes I think is helpful, right when we're intubating someone, doing endotracheal intubation, we go through the cords. That's why obviously you have to visualize through the cords. This is kind of your supraglottic airway. And here's your epiglottis. So basically the Igel kind of comes in and sits right in this area, it creates a seal this way so that it doesn't go down into the esophagus. Obviously the esophagus on the posterior side. So that's what the Igel is and how we use it. The Igel has some pretty unique features that really the goal is to make it as easy as possible to place these. So the Igel has the soft kind of jelly end that is non-inflating. So this is actually really helpful, not as it can be used in air and there's no pressure variation when you fly. It's got kind of this longer area that's more the firm area with a bite block area that's on the tube. This like thickened area has the buccal cavity stabilizer, and it's kind of flattened to prevent kind of movement. There is a gastric port in the Igel for placing an OGT after placement, and then obviously the oxygen port and just hook up to ventilation and things like that. So it's its design is pretty good and pretty seamless. So the advantages of the Igel. So obviously supraglottic airways have their own advantages, and the Igel has advantages on top of just the general supraglottic airway. The Igel allows for blind insertion, meaning you don't have to have your laryngoscope in there to try and see what you're doing. It has ease and speed of insertion, meaning it's not meant to be super complex and it can be inserted pretty easily. There's no inflation of the device or any other device needed. Literally, you just need usually the Igel and a few other tools, which we'll get to. There's minimal risk of trauma. There is the gastric port that we talked about. It can be used at any altitude, and it has that bite block so that if the patients start trying to chew on it, they can't successfully do that. So Again, the indications for use for the Igel here in our ICEMA protocol are the patients have to meet all of the following criteria. They have to be unresponsive. They have to be apneic, meaning they're breathing less than 8 breaths per minute. They need no gag reflex. An appropriately sized airway is available. And then there's unsuccessful airway management with BVM or endotracheal intubation. In ICEMA, we will have 3 sizes of the Igel available, and you can use them based on weight. The yellow is for our lightest weights adults. It's 30 to 60. The green is for 50 to 90 kilos, and the orange is for our largest patients of 90 plus kilos. And we'll have all of these sizes available. Again, the supraglottic airway is permitted only in patients who are taller than the Broslow tape, measuring from head to heel. So these children that aren't above the Broslow, we do not use the Igel on. We just really want to make sure we're not using these in pediatrics because their use in the field right now, that would be an off-label use. And as ICEMA, we're trying to not use it as an off-label use. So contraindications. So we've talked through why we would use the Igel and in what scenarios we'd use it. And then these are our contraindications to use for when we would definitely not use the Igel, even if we were running into some airway challenges with the other routes. So the patients, if they're conscious or have an intact gag reflex, this is a contraindication to use. If there are known ingestion of caustic substances, so this is someone who is attempting overdose or some sort of dangerous behavior. If there's a suspected foreign body airway obstruction, obviously the Igel would not be a preferred airway management. If there is facial or esophageal trauma. And this one obviously is, I know, is a little bit of a vague statement, and we're using some of this to trust your provider discretion on the facial and esophageal trauma, basically meaning kind of disfiguring trauma that makes it that you cannot get the Igel into the patient's mouth is what I would define as facial trauma. An example of, someone who has some periorbital swelling from getting duct in the forehead and for some reason has the other indications for use and needs this airway, if you can successfully place the Igel and they have the anatomy that's not disfigured, you can still use the Igel if needed. And the last one is patients with known esophageal disease, cancer, these patients who have had laryngectomies or esophagectomies, variceal, esophageal varices, surgeries, things like that. These are all contraindications to using the Igel. So these patients, if they have any of the above, you should not attempt Igel placement for. So now that we know when to use it and when not to use it, the next thing is obviously using it. How do we use it? Very similar, right? A lot of this you'll have done already because you have prepared and attempted endotracheal intubation. So the patient positioning and things like that is all stuff you've probably done. But we'll walk you through how to do the procedure and then we'll show you a little video for it. So obviously the most important, things to get a successful airway are preparing in advance. So position the patient in an as optimal position as possible, the sniffing position if you can. Obviously, if they're in C-spine and need C-spine stabilization, please keep them in that. Prepare your equipment before you attempt. Get your suction ready in case you need to suction out before you attempt placement. Get your BVM ready. Get your lubricating jelly and your end-tidal CO2. Obviously, pick a size based on the size of the patient. I showed you all of the sizes because there are Igels for children that fit on the Broslow tape. But again, we're only having the size 3, 4, and 5 Igels available to us. Then you do what you similarly would do if you're planning to do an endotracheal intubation, right? You pre-oxygenate and get everything ready in that way. And then to prepare for the Igel specifically, you lubricate the Igel. So basically you take the lubricating jelly that we have. You don't want to lubricate too soon. So you want to do it as, once you've gotten all your supplies set up, you're pre-oxygenating, lubricate the Igel, putting the jelly on the surface, the gel surface, basically on the front and the back. Then you take the Igel and you insert the Igel, aiming it towards the roof of the mouth or the hard palate, kind of doing a continuous firm pressure until you meet definitive resistance. Once you meet that definitive resistance, you attach your BVM and your end-tidal and you listen for breath sounds to confirm placement and confirm that you're actually having successful ventilation. You secure the Igel with the tube holder that you already have or tape, and then you constantly are reassessing and documenting to make sure that you are your airway has continued to be in the right spot. there sometimes can be a slight like give way in between or as you're passing it, but it's not definitive resistance. It's almost like you're inserting and kind of gives a little bit more. That is kind of the eye gel passing a small part of the anatomy on its way to resting in the supraglottic airway region. Okay, so this is showing how to insert the eye gel and kind of going through some of what we're doing. So these people obviously prepared their patient. The patient is in the sniffing position in the best way possible, obviously in a much more controlled environment than you guys are used to. And the video here is not showing them pre-oxygenating, but I know that that's kind of, we want that in your practice. So you have the patient in the sniffing position. You get them ready. You are at the head of the bed or in the airway chair. Open the patient's mouth, aiming the eye gel towards that hard palate or the roof of the mouth, because basically you want the eye gel to kind of course along the roof of the mouth area as it goes backwards. It kind of goes down into that area. So again, just kind of a slow, constant pressure, basically until it stops. Don't kind of do excessive force. Just keep kind of trying to do the pressure as best you can, the constant slow pressure. Again, this is a blind insertion and your fingers do not need to go into the patient's mouth. You just need to open. Okay, so you feel as if you've successfully placed the eye gel. Congratulations. Now we've got to prove that you've done it. So the correct placement is the tip of the airway is in the upper esophagus and the cuff is against the laryngeal structures like that epiglottis. And kind of the teeth are resting on the bite block, the incisor teeth. The incisor on the eye gel, there actually is a horizontal line that shows roughly where the bite block is supposed to be. So again, here's your epiglottis and kind of here's coursing down into your esophageal area. And so the eye gel is basically meant to kind of come in, track past this food bolus and sit kind of right in this area where the tip of the eye gel goes in here. And basically the opening of the eye gel on the bottom goes in this area so that you can pass into your vocal cords. So it kind of sneaks down here. The side that is closest to the bite block, the top of the eye gel sits here, and then the airway opening kind of goes here so that when you're bagging, the air can kind of go through the vocal cords, obviously into the trachea. I hope I explained that okay for you guys. Okay, confirmation of placement. So again, just like when we do endotracheal intubation, we want to confirm placement here. We do continuous pulse ox and end-tidal CO2, which again, you should be doing both of those things prior to attempting placement. So it should just be continuation of that. Auscultation of breath sounds and chest rise, similar things to what you do when you try and confirm endotracheal placement. Again, the eye gel can hold the gastric tube or an OGT. So this is the sizing that is recommended by the eye gel manufacturer for placement of a gastric tube. So to place the G-tube or the OGT, you basically will, again, use the lubricating jelly and put it on the end, put it kind of at the entrance of the gastric port as well as on the end of the OGT. And you gently just kind of move the catheter or the OGT and try and just place it slowly into the eye gel until it's at the appropriate depth that it should be for when you place it in other ways. Do not place an OGT on patients if you have concern for an upper GI bleed or esophageal trauma, which, if we kind of remember, these patients shouldn't be getting eye gels in the first place given our contraindications. Okay, troubleshooting. If you are trying to get the eye gel and you're not having success. If the resistance is met really, really early and you're not having successful bagging, the first thing to do is just do a jaw thrust. So just kind of go by the angle of the jaw and do the jaw thrust maneuver and see if that helps, and then see if you can pass down. If you're in, but you're thinking you're having excessive air leakage, obviously consider improper placement, such as too high, leading to that airway opening of the eye gel sitting, not creating a good seal, or sitting too low, meaning that the eye gel has possibly gone down into the glottic area and not the esophageal opening. If again there's an excessive air leak, you can then try to ensure that you're giving the appropriate tidal volume to the patient. And if you still have a continued air leak, you can remove the eye gel and try and increase one size, assuming you're not already using the eye gel size 5, and see if that helps with your air leak. So in general, the eye gel is actually a pretty safe supraglottic airway to use, but there are some risks associated with it. And whenever we do or use a device or do a procedure or a medication, we should know the dangers of it. So the most common risks and complications are that you can have trauma to the tissue. Obviously, this is minimized if you are doing not like profoundly hard pressure or anything like that. You can have downfolding of the epiglottis during placement, which then obviously is blocking off your area for ventilation. You can have aspiration of gastric contents. You can have nerve injury, the vocal cords, the lingual or the hypoglossal nerve. It is possible. You can get laryngospasm, and probably the most common complication is patients can have sore throat afterwards from the ventilation. Okay, so we've kind of walked through and hopefully started to address most of the objectives for the Igel and how to successfully use it in the field. And to kind of hit home these points, we wanted to just do a few cases that will basically highlight some of the things that we talked about and give you a chance to like critically think through what you would do in these scenarios. So case 1 is a 42-year-old male. He's being transported by your agency after a motorcycle accident. You're having difficulty managing the airway due to copious amounts of blood, and the patient loses pulses. After obtaining ROSC, you make 3 attempts to intubate without success. What is the next step? Give me a moment to think about it. Okay, so the answer would be that you would suction and attempt placement of the Igel. BVM and intubation attempts were unsuccessful in this patient, and so this patient could benefit from an Igel placement. So this case is right, it was a trauma case. I didn't give you a ton of details of what happened, but it was a traumatic arrest. You got ROSC and were unable to get the intubation, and we're having some challenges with bagging. So you want to, because of the copious amount of blood in the airway, so you want to suction and try and place the Igel and see if you can have successful ventilation. Case 2, a 52-year-old male is transported post-ROSC after experiencing chest pain prior to his cardiac arrest in the field. The patient continues to be apneic, and airway management is difficult with a BLS airway because of his body habitus. The patient is estimated to weigh 225 kilos. His vitals are the following. Blood pressure is 90/60, heart rate is 119, his respiratory rate is 12, assisted by you, and his pulse ox is 90. What is the appropriate next step in the management of this patient? Okay, so the actual answer for this would be attempt endotracheal intubation. So this one was meant to be put in here because as experienced paramedics, a lot of times you guys can see and know if you're going to have hard intubations, which patients will probably be a challenge. And this patient obviously sounds like and looks like they would be difficult to intubate. But according to our policy, the most important thing is we want to use the Igel as a supraglottic airway as your backup to endotracheal intubation. We prefer and desire that if the patient's airway needs to be managed more than BVM, that we absolutely attempt endotracheal intubation first. And if we do not have success with that, then you can proceed to the Igel and go through the process of placing the Igel. And then our last case to review. We'll say it's a 61-year-old female with a history of esophageal cancer, status post esophagectomy. You obtain ROSC after cardiac arrest in the field. While transporting, you attempt to intubate 3 times unsuccessfully. What is your appropriate next step for this patient? Okay, so this patient obviously, because you were attempting intubation, we're having maybe some oxygenation or ventilation issues. But this patient should not have an attempt at an Igel place because this patient meets contraindications for Igel placement. She had known esophageal cancer with known surgery, which is one of the contraindications for use. Other of those contraindications to remember are the foreign body, the trauma, so just remembering what your contraindications are, and if you want to manage that, so for this patient, instead of attempting Igel placement, BVM as best as you can. You've tried your intubation and it wasn't successful, and just try and get to your definitive location and to hand off the patient as quickly as possible and safely as possible. Okay, so you've been listening to me talk. This is the Igel, we're excited to have it roll out here in ICEMA as another airway adjunct for you. But obviously, before we want you attempting this on patients, we want, like your real patients in the field, we want to make sure that you're capable and confident to be able to do this for your patients. So this is it's kind of hard to read, I know, but just want to give you an example of what your skill sign-off sheet will look like, which is basically kind of reiterating a lot of the things that we talked about here. How to keep yourself safe and your patient safe, when do we use it, how do we prepare to use it, what's the process of actually doing the procedure, and how do we kind of troubleshoot and monitor that our airway is still successful. So if you have any other questions, obviously go to your agency's educators, and also you will be signed off at your individual agencies. So this is just the starting process to hear about what the Igel is like, and then now you'll be able to work with your agencies to actually get the hands-on experience and see and use the Igel. Here are some references, and thank you for listening. I hope you enjoy.